Welcome to Nexus Medical Media. In this video, we are going to talk about schizophrenia. Right, schizophrenia literally means the splitting of the mind. Right, so we're going to start with a case from USMLE STEP2. A 27-year-old woman is brought to the emergency department by the police after being found walking down the middle of a busy highway saying she is blessed with the power to save all souls. The patient believes she is the reincarnation of the Savior and the long-lost daughter of the president. She has been homeless and unemployed for the past year. The patient claims she has no psychiatric history, but later says some bad doctors tried to trick me into taking poison when I was in the hospital last year, but I outsmarted them. Physical examination show a disheveled woman with poor hygiene. She smiles and laughs for no apparent reason. Her speech is rambling and difficult to follow. Routine laboratory tests are within normal range. Urine drug screen is negative. Which of the following is the most likely diagnosis in this patient? A. Bipolar disorder, manic episode with psychotic features. B. Brief psychotic disorder. C. Delusional disorder, grandiose type. D. Schizophrenia. E. Schizophreniform disorder. F. Schizotypal personality disorder. Right, so to understand a case like this, you need to know about psychotic spectrum disorders. Right, so in this spectrum, you find a brief psychotic disorder, schizophreniform disorder, and schizophrenia. Right, so the classification I'm going to base on DSM-5 criteria. Is from US, is easy to use. Another classification is ICD-10, and now there is ICD-11, right? So this is recommended by the WHO, right? Okay, so before we do that, let's talk about psychosis, right? So psychosis is defined as a detachment from reality in thought or action, and psychosis is a symptom, not a diagnosis, because it occurs in different conditions. Psychosis is characterized by hallucinations, delusions, disorganized speech or thoughts, disorganized behavior, and all negative symptoms like apathy, withdrawal, avolition, etc. Right, so let's talk about this disorder, starting with the brief psychotic disorder. Right, so the duration is less than 1 month. Right, but it's more than 3 days. Why more than 3 days? Is because from 0 to 3 days, the cause of psychosis could be an organic cause, so you have to wait for the non-etiology to subside before treating the patient. Right, so brief psychotic disorder, less than 1 month. Less than 1 month according to DSM-5, right? So according to ICD-10 is less than 2 weeks. Next is schizophreniform disorder. Right, so schizophreniform disorder symptoms are between 1 month and 6 months. Right, so it's more than a month but less than 6 months. Right, so if we are using ICD-10, it will be more than 2 weeks but less than 1 month. Then schizophrenia, right? So schizophrenia, the symptoms are more than 6 months. They last more than 6 months according to DSM-5, but more than a month according to ICD-10. Right, I know this is a lot, guys, but just get used to it. You just choose any criteria you would like to use. As for me, I like ICD. I like DSM-5 because it's easy, right? Okay, so that's the basic definition of schizophrenia, right? So schizophrenia is actually difficult to define, but we can define it as a chronic disease that has psychotic symptoms lasting more than 6 months and has gradual deterioration of occupational and social functioning with time. Right, so some basics you need to remember when we talk about schizophrenia. From number 1 to 5, this box is very important because most MCQs will come from this box, right? So schizophrenia is a global prevalence of 1 to 2%. The lifetime risk of developing schizophrenia is about 1%. The usual age of onset is 14 to 54 years. Males tend to develop it earlier than females. Males also tend to develop more severe symptoms, so they have poor prognosis. Right, please remember these 5 points. You are going to see them in one of your MCQs. I am sure of that. Right, the diagnosis of schizophrenia carries a 20% reduction in life expectancy, and suicide is the common cause of premature death in individuals with schizophrenia. Right, diagnostic criteria. Right, so as I said, the diagnostic criteria for schizophrenia differs according to whether you're using ICD-10 or DSM-5, but they are more or less same thing, right? Okay, so the hallmark of symptoms of schizophrenia are hallucinations, delusions, disorganized thinking. Right, so according to DSM-5 criteria, right, so they are 1, 2, 3, 4, 5, 6 criteria that you need to know. The first one is characteristic symptoms of schizophrenia. B, deterioration of social and occupational functioning. C, duration. D, not a result of any other non-psychotic illness. E, substance abuse and medication and medical condition, right? So it should not be because of substance use and medical condition, right? So another one is part F. I'm going to show you as we proceed, right? So let's talk about these one by one, starting with characteristic symptoms, right? So any 2 of the 5 symptoms are required to diagnose schizophrenia, and these symptoms are required to be present for a significant proportion of time during a 1-month period or less if it has been treated, right? So the symptoms, these 5 symptoms, are hallucinations, delusions, disorganized thoughts and speech, grossly disorganized or catatonic behavior, right? So these 4 are known as the positive symptoms, right? So positive symptoms are called positive because it's something a person with schizophrenia gains. It's something that is normally there. It's not normally there, but you gain it, so it's a positive, right? Because negative symptom is something that you don't get, something that you lack, like avolition, withdrawal, right? Okay, so we're going to talk about these one by one, right? So starting with hallucination, right? So what's the basic definition of a hallucination, right? So a hallucination is like a perception of a stimuli that is not there, right? So for hallucination to be counted as a psychotic symptom, it has to be experienced while the patient is awake and fully conscious, right? So it's hearing voices, auditory hallucination, and like seeing things that other people can't see. Those are visual hallucinations, right? But the hallmark is that the patients need to be awake and fully conscious. So delirium hallucinations are therefore not considered as part of psychotic symptoms because like there is a clouded consciousness in delirium, right? Next are delusions. What are delusions? So these are ideas that are firmly believed by the patient despite the belief being clearly false or having been proven wrong by the evidence and should be culturally inappropriate, right? So the delusions, these are the ideas that they are not in keeping with one's culture, tradition, religion, etc. Right. So delusions should be differentiated from overvalued ideas, which are ideas that may not be true but have neither been proven true nor proven false. For example, is the superiority of one's own race or the place a person lives, right? Disorganized thoughts and speech, right? So typically patients with schizophrenia have loosening of association. This is basically like when you talk to a patient, they will be jumping from one topic to another and the topics are actually unrelated, right? It's called loosening of associations. There's going to be a separate video talking about the symptoms in schizophrenia, right? So I will cover that in another video, right? So to be regarded as psychotically disorganized, the speech must be so badly impaired that it interferes with the communication. Grossly disorganized or catatonic behavior, right? So this entails behavior that is not goal oriented. A good example is disrobing in public, posturing, and repeated movements. Next are the negative symptoms, right? So these include a reduced range of expression of emotion, for example, flat or blunted affect, withdrawal, reflected as a markedly reduced amount and fluence of speech, and avolition. This is lack of will to do things. They are called negative symptoms because they give the impression that something has been taken away from the patient. And the negative symptoms are difficult to differentiate from downness due to depression, drug use, or ordinary lack of interest. Right. So this is the general classification of these symptoms that I just mentioned. Right. So they are positive symptoms, negative symptoms, and cognitive symptoms in schizophrenia. Right. So positive symptoms are deviant symptoms. These are symptoms that are present but should be absent, and they indicate that the patient has lost touch with reality, right? So these are hallucinations, delusions, disorganized behavior, and speech. Negative symptoms, these are deficit symptoms, right? So these symptoms reflect the absence of normal characteristics, and they include apathy, anhedonia, blunted affects, and poverty of speech. Then cognitive symptoms, right? So these reflect the patient's abnormal thinking, poor decision making skills, poor problem solving skills, and the ability to communicate, and his strange behavior, right? So here there will be thought disorders and bizarre disorders. Right. So to sum up the characteristic symptoms, let's talk about Kate Schneider's first rank symptoms. Right. So if any of these symptoms are present, they are pathognomonic or highly suggestive of schizophrenia, but none are necessary nor sufficient, right? So they are just highly suggestive, right? So I remember using the mnemonic 313, three types of auditory hallucination, one type of delusion, and three kinds of thought disorders, right? So the types of auditory hallucination include a thought echo, right? So audible echo, like when you can actually hear your thoughts, right? The second one is third person auditory hallucination. This is hearing people talking about you. And then running commentary is more like if you like watching soccer, those commenting like, I see him, he is doing that, now he is touching what. That's an example of running commentary, right? So that's what the person will be hearing. One type of delusion is delusional perception, right? So this is a good example is the robot, right? Let's say the husband is driving with his wife, and then the robot turns red. Then Yeah, so there is a stimulus, right? There is a stimulus there, but interpretation now. Then the person will say, because the robot is red, it means you are cheating on me. Yeah, that's perception or delusion. Okay, then three kinds of thought disorders. These are thought withdrawal, thought insertion, and thought broadcasting. Right, thought withdrawal is feeling like your thoughts has been taken from you. Thought insertion, this is like a feeling that these thoughts are not mine. They've been inserted maybe by aliens or the chip in my brain, for example. And the thought broadcasting, right? So thought broadcasting is the feeling that my thoughts are being heard, like people are hearing my thoughts, right? So thought block is not in this category, right? Because it can be caused by absence seizures, right? So thought block is not there. And the other symptoms are passivity phenomenon, right? So feeling of control, like you are under control of something. Like, what did you do? Why did you do that? And then the person will say, the devil made me do it. Okay, right, right. So I saw another one in a certain textbook. It was also mentioning like somatic hallucination, right? But for you to be safe, just remember these three types of auditory hallucination, one type of delusion, three kinds of thought disorders, and passivity phenomenon. You will be fine, right? Category B, deterioration of occupational and social functioning. For a significant proportion of time since the onset of symptoms, the level of function in one or more major areas of work is markedly below the level achieved prior to the onset of symptoms. The major areas considered are work, interpersonal relationships, and self-care. If the onset is in childhood or adolescence, the major areas considered are interpersonal, academic, and occupational function. Next category is duration, right? So the disturbance must continuously persist for 6 months or more. This period must include at least 1 month of symptoms that meet criteria A, if you remember the hallucinations, the delusions, negative symptoms, etc., and may include periods of prodromal or residual symptoms. During these prodromal periods, the signs of disturbance may be manifested only by negative symptoms or by 2 or more of the other symptoms listed in criterion A present in attenuated form. D, right? So this should not be a result of any other non-psychotic illness, right? So schizoaffective disorders and depressive disorders or bipolar disorder with psychotic features has been ruled out because, number one, no major depressive or manic episodes have occurred concurrently with the active phase symptoms. 2, if mood episodes have occurred during active phase symptoms, they have been present for the minority of the total duration of the active and residual periods of the illness, right? So basically what this means is that to diagnose schizophrenia, you need to rule out other psychiatric illnesses with psychosis. That's it basically. E, this should not be because of substance use and medical condition, right? So the disorder should not be a result of physiological effects of a drug of abuse or any medication, and it should also not be as a result of a medical condition. F, right? So this is what I mentioned previously when I told you the general criteria: history of childhood disorder, right? So if there is a history of autism or other childhood onset communication disorder, the additional diagnosis of schizophrenia is only made if prominent delusions and hallucinations, in addition to the other symptoms of schizophrenia are also present for at least a month. Now, the exact cause of schizophrenia is unknown, but there are risk factors which have been known to be associated with schizophrenia, right? So let's talk about those risk factors. First one, first degree relative with a history of psychosis. This is genetics, right? So the lifetime risk of these patients increase from 1 to 10%. Right, so because I said just prevalence is 1 to 2%, right? But if you have a first degree relative with a history of schizophrenia, right, so the risk will be 10%. Monozygotic twin concordance is 20 to 40%, while dizygotic twin concordance is 10 to 20%. The thinking is that there is a gene or group of genes responsible for generating these symptoms. It is unlikely that a single gene can be responsible for all or most cases within family. Rather, there may be multiple susceptibility genes that make someone more likely to develop schizophrenia. Next is obstetric complications during birth. Maternal prenatal malnutrition and antepartum viral infections increase the risk of schizophrenia. Other conditions include preeclampsia, low birth weight, emergency cesarean section. These may reflect underlying genetic abnormalities or hypoxic brain damage. Next, substance abuse. Right, so cannabis, amphetamines, cocaine, and LSD can produce psychotic symptoms. Cannabis on its own does not cause schizophrenia, but increase the risk in individuals that are susceptible to developing the condition. Smoking cannabis 50 times during teenage years makes you 6 times more likely to develop schizophrenia, and adolescents are very vulnerable since their brains are still developing. Right, so there is a type of cannabis called a skunk cannabis, right? So this is a one type of cannabis that is more likely to cause schizophrenia. Next, like the where the person is living, urban versus rural dwelling, right? So urban dwellers are 2 times more likely to develop schizophrenia than rural dwellers. This may be due to drift or stress specific to the urban environment. The next risk factor is like adverse life experience. Sexual or physical abuse, right, both in childhood and adulthood, may increase the risk of schizophrenia. Psychological treatment to address this may be an important part of management. Socioeconomic status. This is questionable since people with schizophrenia experience a socioeconomic drift in which they gradually drift into low socioeconomic groups. Clinical presentations. Now there are 3 phases, right? So phase 1 is prodromal phase. This is known as the at-risk mental state or ARM state, and this phase precedes full-blown schizophrenia. It consists of low-grade symptoms such as withdrawal, loss of interest in work or study, that's anhedonia, relationships. These are minor vague negative symptoms, right? These patients who just want to stay alone, not talk to people, etc. This phase occurs without any frank symptoms, and it is recognized that 80 to 90% of patients enter this phase. The picture is that of someone in their late teens, that's early 20s, who has dropped out of school after a period of increasing absences. The patient often seems distant and gives no reason for isolating themselves. and they may deny vague psychotic symptoms for fear of their significance, right? So the person might see something, but if you ask the patient, like, are you seeing something that other people do not see? They will say no, right? Just because if they say yes, it means they'll be admitting that something is going to be, something is going to happen, which is actually worse. The second phase is called the acute phase, right? So this phase is the most striking and florid psychotic features. The positive symptoms include delusions, hallucinations, disorganized thinking, right? So these are present in this phase. Negative symptoms can still be present during this period. Hallucinations in schizophrenia are typically third-person auditory hallucination, and the patient also have running commentary and thought echo, right? According this I told you in the Schneider's first rank symptoms. The most diagnostically significant delusions that patients develop are delusional perception and perceived phenomena, right? So delusional perception, remember that a robot example, and perceived is control. Patients also have thought interference and persecutory delusions. The third and final phase is the chronic phase, right? So this is a phase ended by some patients instead of becoming well, right? So some people actually recover, but other people go to chronic phase. This chronic phase is mainly characterized by negative symptoms: apathy, blunted affect, anhedonia, thus inability to enjoy previously interesting interest or activities, poverty of thoughts and speech, that's poverty of speech as well, and social withdrawal, right? So negative symptoms are very difficult to treat. They may be a lack of personal hygiene and care. They may also be residual positive symptoms, right? So on mental status examination, there are different features that you need to look at. Firstly, on appearance, right? So the patients are often unkempt, poor grooming and hygiene, and has psychomotor agitation or retardation in posturing. On speech, speech varies from coherent to incoherent depending on the severity of symptoms. It is characterized by neologism, word salads in extreme cases. Flow of speech can be normal, or the patient may be mute, like in catatonic schizophrenia. Mood and affect. The mood varies with the circumstances, and the affect is incongruent to the mood. Patients may have flattening or blunting of the face. It's called face mask, right? But this is not a mood disorder, remember. Neurovegetative symptoms, right? So the patient may have insomnia and poor concentration. Nonetheless, weight and appetite are usually not changed unless if the patient has catatonic schizophrenia, like because the person won't be eating, so low appetite and low weight. They have normal energy, libido, and pleasure and interest. There is a greater rate of suicide ideation than in normal population, partly due to distressing perceptions that the patient has. Thoughts. The patient's speech is reflective of the thoughts. These include neologism, word salad, and loosening of associations. Other features include thought interference, that's withdrawal, block, and insertion, derailment, circumstantialis, and tangentiality, right? So derailment, let's say you ask someone a question, then the person starts answering with something related to the question, but slowly derailing, like derailment of the train, like slightly or slowly deviating from the main topic. Circumstantiality, this is done by politicians, right? So they talk a lot of talk about other details which may actually be unrelated to the previous question, but they will come back to the topic and answer, right? So they talk about other unrelated details, and then they will answer later. Then tangentiality. Okay, so this is actually ways. Let's say you say, okay, what's your name? Then the patient will say, my mother is very fine. That's tangentiality. The patient may also have delusions, and these may be paranoid delusions or perceptual delusions. Perception. The hallucinations are common positive symptoms. They are typically third-person auditory hallucination accompanied by running commentary, thought echo, and they may have a visual hallucination as well. Cognition. The patient is usually fully conscious of what they are doing, although orientation is usually impaired in time and place. Attention and concentration are also defective. The intelligence is normal, but the patient has concrete thinking. That is, they take things literally, right? So let's say you give a person a proverb, they will just take the literal meaning, or I mean, they will just like do literal translation of those figurative statements, and their judgment is poor, and insight is poor, or we can actually say it's bizarre. For example, if you ask the patient, like, what do you do if you see a child on the side of the road? Then the person with schizophrenia can say, okay, I'll take the baby and then I'll just throw him up, or I just put him in a tree so that people can see when they pass by. Yeah, that's bizarre judgment. Right. So there are different types of schizophrenia that I would like you to read about. These include paranoid schizophrenia, catatonic, which I mentioned several times in the previous slide. In this case, you have a stupor, you have fear, you have wax rigidity, posturing. There is disorganized or hebephrenic schizophrenia, undifferentiated, so undifferentiated doesn't fit in all of these, and residual symptoms, the remaining symptoms, right? So this is just beyond the scope of this lecture, but you have to read about these different types of schizophrenia because you're going to see them in your MCQs. Investigations, right? So a full physical workup is required, not only to exclude organic cause, but also to pick up comorbid physical problems and ensure baseline tests have been done before starting an antipsychotic, right? So you may be busy treating psychotic features, but the patient can actually die because of other things. So that's why you need to test like a lot of features first, right? So a full physical examination and vital signs. Then you do blood tests like full blood count, UNEs, liver function test, thyroid function test, erythrocyte sedimentation rate, CRT, CBG, lipid profile, right? So a routine HIV testing is advisable, and consider syphilis serology. Urinary drug screening, right? So this one can identify common illicit substances, for example, cannabis, amphetamine, but many drugs like NPS, we cannot detect it in the urine. Baseline ECG, this is ideal before starting antipsychotics. Additional tests are indicated if the clinical presentation suggests organic pathology. For example, you can do CT or MRI of the brain in older patients, those with history of head injury or focal neurological signs, but routine neuroimaging is not indicated. EEG, right? So if epilepsy or other organic cause is suspected, for example, prominent confusion, you do EEG. Then the most important part is a collateral history, right? So this is very important because you see, like this patient with schizophrenia doesn't have all the answers. Sometimes they won't give you anything. You need to see someone who has been with this person before the before these symptoms, and then you get to understand also how these symptoms, how the disease is affecting the family in general, right? So this is collateral history is very important. Then in management of schizophrenia, right? So the management, you need to remember this. The management has 4 parts, right? So this include medication, that's psychopharmacology. Then there is psychotherapy, social intervention, and rehabilitation, right? So in medication, right, so the basic antipsychotics is chlorpromazine, but here in our local system in Zimbabwe, haloperidol is on number 1. You can also use sulpiride, olanzapine, risperidone, clozapine, fluant. Okay, I don't know. Can you try, guys? Clopixel, right? So deca preparations are oil-based and stay in muscle for up to 2 weeks. For example, flufenacin decanoate, right? So these are good for uncooperative patients, not uncooperative, but those who can actually default treatment, right? So they just get these injections. Right, so just to remember, 5 milligrams of haloperidol is okay. Next is a psychotherapy, right? So psychotherapy applies in every psychiatric condition, and it consists of 3 parts. Psychoeducation, right? So in psychoeducation, the patient and family need to be educated on the illness and the implications and medications, right? Supportive psychotherapy. This ensures patient has adequate support from the family and friends. And family therapy may be necessary to reduce high expressed emotion. And the third part of psychotherapy is token economy, where a reward system or a reward is given to a patient for doing something good, right? So it's called token economy. Right, so they are prognostic factors, good and bad, right? So I'm sure if you read your textbook, you see a table with bad and good prognostic features, right? So here I just took these 5, right? So these 5 are for poor prognosis, right? So there is poor prognosis if there is a strong family history, if there is a gradual onset, low IQ, prodromal phase of social withdrawal, and lack of obvious precipitants. Right. So there's one more thing that I really needed to mention about catatonic schizophrenia. So in catatonic, we're saying like this patient is not eating. The patient can actually die. So you should consider like electroconvulsive therapy. Right, okay, so let's go back to our case and finish this video. Right, so let's just read it again, underlying the keywords. Right, so a 27-year-old woman is brought to the emergency department by the police after being found walking down the middle of a busy highway, saying she is blessed with the power to save all souls. Right, so this is disorganized behavior, right? So this is grandiose delusion, right? She believes that she is the reincarnation of the savior, is grandiose delusion, and the long lost daughter of the president is delusions of grandeur again. She has been homeless and unemployed for the past year. Right, so this shows the occupational and social functioning, right? And again, for the past year, it's more than 6 months. The patient claims that she has no psychiatric history, but later says some doctors tried to trick me into taking poison when I was in the hospital last year. This is persecutory delusion, but I outsmarted them. Physical examination shows a disheveled woman with poor hygiene. Right, so they are unkempt. She smiles and laughs intermittently for no apparent reason. Her speech is rambling and difficult to follow. Routine laboratory tests are within normal range. Urine drug screen is negative. Which of the following is most likely diagnosis? Yeah, is schizophrenia. Now let's see why other answers are wrong, right? So this question wanted you to understand this concept. This patient's multiple delusions, disorganized speech and behavior, and evidence are suggestive of impaired functioning for more than 6 months. For example, hospitalized the last year, or homeless and unemployed for the past year, are consistent with schizophrenia. Patients with schizophrenia can have grandiose delusions that they possess special powers or are related to or have common or have become someone famous. Sorry. Other common types of delusions include paranoid delusions, delusion of reference, that's, for example, receiving special messages from an electronic media, right? For example, the patient is watching news and then there is this news sign language, and then the patient will say they are sending me a special message. Those are ideas of reference, right? So the second answer, our first answer, A, was saying bipolar disorder in the manic episode with psychotic features, right? So this was wrong because the patient experiencing manic episodes of bipolar can also have grandiose delusions. However, these patients typically have an episodic, right, not chronic cause, and associated with symptoms of elated mood, increased energy, hyperactivity, and decrease the need for sleep, which are not present in this patient, right? So this is not present, so is less likely to be bipolar. And the patient with mania have an intense, elated, or irritable affect consistent with their mood, whereas this woman has a bizarre and inappropriate affect, for example, smiling and laughing out of context, like for no reason, suggesting that she is responding to internal stimuli, right? So in addition to this, patients with mania typically have pressured speech that is difficult to interrupt, and the patient's speech is disorganized and rambling. Choice B was saying brief psychotic disorder, and choice E was schizophreniform disorder, right? So brief psychotic disorder is characterized by one or more psychotic symptoms lasting for less than a month. It is not diagnosed unless the patient shows complete resolution of psychosis with a return to premorbid functioning. A diagnosis of schizophreniform disorder is made when all of the clinical features of schizophrenia are present, but the duration of symptoms is less than 6 months, right? So schizophreniform, and brief psychotic disorder is all about time. In addition, in brief psychotic disorder, the person will return to the normal premorbid functioning. Choice C was delusional disorder, grandiose type, right? So patients with delusional disorder do not have other psychotic symptoms, which are characteristic of schizophrenia. For example, disorganization and negative symptoms. In contrast to this patient, they may function normally apart from the impact of the delusions. Choice F is a schizotypal personality disorder, right? So the patients with a schizotypal personality disorder have odd thinking, like Doc Brown, if you like. It's Back from the Future or something like that, right? And perceptual disturbances that are sub-threshold for diagnosing schizophrenia. And this patient is clear delusion and grossly disorganized speech and behavior are characteristic of schizophrenia, right? So we'll talk about all these other options in separate videos, like personality disorders, bipolar affective disorder, schizoaffective, etc. Right. So I hope this video was helpful. I mean, this was long, but I'm sure after watching this video, you can go to your textbook, read it through, and these concepts will be clear and will be ready to ace your exam. Until next time.